Hello, and welcome to the Solutions Manual podcast, where we take life's greatest challenges and turn them into simple, practical solutions that you can actually use. I'm Sarah, and I'm fascinated by nutrition, well-being, and human performance.
And I'm Maciek, a physician and medical leader passionate about helping people unlock their potential. What unites us is a deep fascination with how the human brain works and how to train it.
Together, we will show you how you can rewrite your life story by retraining your brain.
Join us as we explore the intersection of science, the brain, leadership, and personal growth. Let's get started.
Yes, there are actually a few reasons for this being my favorite topic. I will start with the personal bit, going to my personal experience. And I always thought that being a doctor, that would mean being better prepared. Even in my case, my own mother went through early menopause, so I was a witness of her struggles. And in spite of all this, it still came as if out of the blue. And nobody prepares you for it until you actually have to deal with it. And the other thing is, it's very easy to, even if one wants to be prepared, to read the symptoms and say, yes, I know all of them. But actually, it's so individual. Each woman would experience different symptoms with different severity. So it's very difficult to be 100% prepared. And in my case, it started with noticing that the concentration ability was not like before, but also because, and that's why I really love your podcast in terms of topics you cover, because I have always been very keen to increase productivity, increase strength. So I've always been very physically active. I have very healthy lifestyle, healthy eating, very keen to have peak performance all the time, if possible. And I think when one is so keen to monitor changes, for me, I became more acutely aware that things are different from before. And again, doing the same exercise, that also helps to know what has changed if one does it consistently over decades. So for me, that was the main thing. Of course, it coincided as well. I had to go through fertility investigation in my late 30s. And in a way, that was a blessing in disguise, because that's when they found that the eggs were just gone. And for me, it was difficult to reconcile that I've always been so healthy, active, everything. I've ticked all the boxes, and all of a sudden, how come? So I had to deal with this. But again, the blessing was that I already knew what was coming. So once the symptoms started getting worse, it didn't take me much longer than that, even though I was very close to my 40s at the time, to being 40. So in a way that helped. But the real motivation came just a couple of years later, when I was a co-investigator on a few studies treating women in menopause. And that was the biggest inspiration for me, because at that point, we were actively recruiting for 4 different studies with different hormonal treatments. One was a non-hormonal treatment. So 2 of the studies were with fezolinetant, which is currently on the market in the UK as well.
Yes.
And the other 2 are with a different type of estrogen, which occurs naturally in the body, estradiol. But what we had to do, we had to recruit, of course, a number of women in menopause for these studies. And as you know, with the clinical trials, you go through the screening process when you have to select the right participants. And that gave me the opportunity to speak to more than 200 women in menopause. And the stories I heard were the tipping point. I thought, no, I need to do something about it, whether it's the clinical trials, just spreading awareness. Because of course, most of these women were women who are just different backgrounds, but most of the stories were the GP didn't prescribe, or they were hesitant, or they just offered me this option. And by that point, of course, with my personal story, I had gone through a lot of different options, so I knew what's available. I knew how difficult it can be. So also knowing what the study involved, and sometimes, I knew what are the options available, and I personally, for me, this was a bit of an ethical consideration. We had to ask women to stop using whatever treatment they may be on before they go on the study, and I thought I can't
do this.
I can't imagine myself doing this. But these women were so desperate that they were even willing to do this because for whatever reason their treatment was not at the dose which worked to cover all the symptoms they had. And there were a few other things which came to light in terms of some of the gynecological tests which one needs to go through as part of the investigations, and specifically having the endometrial biopsy. I didn't realize that the usual practice in the UK, and unfortunately in other countries, is without anesthesia. And for me, that was totally unacceptable. Also, because there is a difference. If you go privately, you will be offered the choice of anesthesia. But if you are part of the standard of care, that's not necessarily the case. So many things like this kind of came together, and I thought, no, we need to talk about this. It's a big issue.
And I think, Dani, so you have touched upon a lot of things in that introduction of sorts, and I think there are a few I really want to pick up on. One is, you're absolutely right that clinical standards, especially in public healthcare systems, this is the bare minimum standard. That's not for thriving. This is just to get by. And I think that people need to understand that you're getting the bare minimum, and it's also typically from the cheapest provider. And we also, in clinical medicine, the decisions, especially at the public sort of health or the standards level, are based on evidence. But there are a lot of things that there's simply no trials in. There's just not enough of robust evidence on the populational scale available, right? Hence the need for those trials. And I would love to hear more about how you got into this space. But because your background, you speak from the background of a research physician. My background comes from the surgical experience primarily, and where the focus is on what works, not necessarily what is fully evidence, right? And that was always for me the thing that, okay, I get that there is no evidence, but this works and this doesn't. And it has been practiced in that way with demonstrated outcomes. So you get the evidence after you start the practice, but it's easier in a surgical setting than it is in a, let's say, pharmaceutical setting, right? Or in a medical setting, because the evidence has to come first. And that sometimes is very difficult to even obtain. And so what I would like to kind of bring you a little bit closer to our listeners who might be, one, new to this topic, or two, suffering, let's use that word, when it comes to menopause, right? Yes, it's physiology, but it's something that people don't have to suffer, women don't have to suffer through. So tell us a little bit more about your own clinical research journey, right? What drew your focus to the menopause, and specifically to the brain related or the brain health changes or issues that are affecting women who are entering that age, right? Perimenopause, premenopause, and menopause.
Yes, of course. I mean, you also opened a big area which would be good to know to go into detail. But for me personally, I started working as a clinical research physician in my late 20s. So I have now more than 25 years experience as a research physician. But working on the menopause studies, that was pure luck. If it's up to me, I would be doing this full time all the time. I was working at a research center where we were doing clinical trials in other conditions. And it happened that our site was selected to do specifically this menopause study. So it was, for me, like a coincidence, because it coincided with the period of my life when I knew I was, I had just, I went through my journey. I found what works perfectly. And I looked around and I thought, everybody should be aware of this. And then I started the studies and I realized, wow, it's a very sad situation out there. So I was just very lucky to be involved in these studies. In terms of, you mentioned about, that's the part which is with the clinical trials. But what I did during this time is I started getting involved in the British Menopause Society training. So at that point, I did their very intensive training, which is I completed the certificate of principles and practice in menopause care, which equipped me to be able to get involved in doing further training, to not just within the company teams to train everybody on the menopause, but also providing external training as well. And you mentioned in terms of having evidence-based research, and at that point, so the studies were, my personal journey started about the time the first NICE guidelines appeared. And I found it personally difficult to believe it was 2015, only 2015, when the first NICE guidelines for menopause treatment appeared. So what was going on before that? As we know, the NICE guidelines suggest is, as it says, guidelines which defines the standard of care.
The standard of care is very often behind the latest science. It is based on the quality of available evidence. So that evidence needs to be generated and created first because it becomes the standard. And standard is it's the bare minimum that can be offered to people. And it takes not only medical science, it also takes the cost. So it also needs to be cheap, right? So it's kind of how much money you're paying for, the system is willing to pay for each individual to have access to certain treatments, right? So this is not a breakthrough thriving, not the latest science. That's essentially the bare minimum that can be offered and evidenced. But we know we have a lot of listeners from outside of the UK. So just very briefly on guidelines, I believe there is no one NICE equivalent in the US. There is I think AHRQ, which is the Agency for Healthcare Research and Quality in the US. There is CDC that issues clinical guidelines, but that's primarily for public health and infectious diseases, not necessarily for anything else. There will be National Institutes of Health that will be issuing evidence-based guidelines, and very often professional societies. Preventive Services Task Force, but then again, that's for prevention rather than treatment. And again, professional societies, right? So let's say the gynecological specific guidelines or guidelines for GPs would have their own standards of practice. There is no one unified provider of these as well, right? Which probably adds to confusion and makes even the standard more elusive to women outside of the country, like the UK.
True. To some extent, this is mitigated by there's still, of course, the European Menopause Society, who is producing as well guidelines. But the reason why one would be referring to the country guidelines is because, of course, they determine what the GPs would be more likely able to prescribe. So we can talk about testosterone later, but it really, the guidelines, the national guidelines will put what would be the first line of treatment for a certain condition, and then what condition would be covered, and then it will go into the formulary for the medication which can be prescribed and reimbursed. So if, for example, a certain treatment is, let's say, one of the non-hormonal medications is not mentioned in the guidelines, it still probably will not go on the reimbursed list. So it really makes a big difference if it's already reflected in the guidelines, for which we need the studies, etc. And it was still very important that at that point it was already recognized that women who go through menopause and have depressive symptoms might be prescribed antidepressants straight away, and that was already targeted in the guidelines. So we can go to the guidelines later on, but
it's important to say, again, it's interesting. We see this all over medicine, symptom management, not addressing the problem, right?
Yeah. So we can go into the guidelines now if you want, because it was, for me, it just one of the ways I realized, okay, it's clearly that was long overdue. Luckily, the guidelines addressed this, I would say, bad practice for women who have depressive symptoms associated with menopause to be prescribed on antidepressant. The guidelines was very clear. They should be started on HRT. And of course, if there are additional symptoms which are not helped with the HRT, they should be prescribed then as second line antidepressant. There are a few other important points which the guidelines addressed as well. First of all, mentioning that women are not just suffering from hot flushes and night sweats as part of the menopause. They were referring also to all the other symptoms such as sleep disturbance, mood changes, genital urinary symptoms, sexual dysfunction, impact on bone health, on cognitive issues as well. So all this was addressed there, as well as trying to do some damage control with, as we know, the Women Health Initiative study in 2002, when they reported, not correctly reported, the increased risk for breast cancer, and that was taken by the media as high risk of breast cancer. They have tried to mitigate this because, as we know, this Women's Health Initiative results in 2002 led to many women, just GPs being not willing to prescribe any HRT. Women willingly came off HRT, so the impact was enormous. And even up to this point, I'm still surprised when I see numbers that about 14 to 30% of the women, and that's in the UK, are prescribed HRT. Knowing what are the many benefits of having your hormones topped up by HRT and not having to suffer the symptoms. So luckily this was addressed at the time, and there was the update of the guidelines, which came in November 2024, which also updated on some of the non-hormonal options which exist, and many women may not be aware that even if they have the contraindication for estradiol, for example, they have a history of breast cancer, or for whatever reason they may not want to take hormonal preparation, there are non-hormonal options, and one of them is, of course, the fezolinetant, which I mentioned, the studies with fezolinetant, but there are other options as well, which are mentioned in the updated guidelines. So there are options, but also when one wants to think about the breast cancer risk, I find this extremely helpful. They have these infographics which show, in order to make an informed decision, how many more cases of breast cancer would be if we compare women who haven't been on HRT versus those who have been on HRT for 5 years. And then again, people think, well, if I'm not on HRT, maybe I'm free of the breast cancer risk. But they make it clear that out of 1,000 women who are not on HRT during the postmenopause period, 59 from them will still develop breast cancer. And from those who are on HRT for 5 years, 79 will develop breast cancer. Mm-hmm. And that's not even taking into consideration that, and that's of course also mentioned in the guidelines, that every woman have modifiable and non-modifiable breast cancer risk factors. So all these have to be considered. And once there is more talk about the risk over the last 10 years, it's been mentioned very frequently that the breast cancer risk is the equivalent of the risk one would have by drinking 1 glass of wine every day. Mm-hmm. So, and also the risk of being overweight is actually, in terms of breast cancer, is higher than the risk of taking HRT. And going back to what Maciek mentioned in terms of evidence or lack of evidence, when there is a talk about the risk, is actually referring to studies which are still done with synthetic estrogen and synthetic progestogens, or the synthetic ones. And they're more smaller studies, so not some, usually those wouldn't be necessarily taken as part of the guidelines, but the guidelines also mention that there is not research available so far which is of enough size, so statistical significance, which would demonstrate that the difference between the body identical and the synthetic HRT, which we know from clinical experience that the body identical ones carry much less risk to no risk in some patients, and the risk is higher with the synthetic ones. But the studies still need to back this up, and the reason is that they have to do the studies. Right. So that's just an area for research. Mm-hmm. So much can be done. Yeah.
Because I think there's still some misconceptions about HRT in general. Maybe mechanistically speaking, what is happening during perimenopause and menopause, and cancer risk aside, and breast cancer risk aside, what can we clarify and debunk the myths around HRT, and maybe we can start talking about testosterone too, and then provide recommendations for the types of conversations that a woman can have with their practitioners early about this, and then kind of what kind of information they should listen for when they do have those conversations?
Yes, I will start with first taking a step back, and you can, if I forget any of the questions, you can remind me. So I'll start first with defining what the perimenopause is, the menopause, and also a few terms which people may see as premature ovarian insufficiency, early menopause, and menopause. So perimenopause is the transition period before menopause starts, and menopause is literally a term which defines the 12 months without period after which one enters the post-menopause period. So the period before that, when the hormones start going down or start to fluctuate wildly, it's perimenopause. And there is much talk about the perimenopause as well, because many women suffer even more during this period. Mm-hmm. They have, some women may not suffer at all, but many do suffer a lot. And it's one of the misconceptions is that one needs to wait until menopause starts before one can search treatment. And that's just not the case, because the reason why the symptoms are so severe during this period is because estrogen levels go down, they produce the symptoms, progesterone levels go down, or they fluctuate a lot. But we have the evidence that if one starts treatment during this time, symptoms will be largely under control. So why wait to suffer? And the main something people may want to remember is we don't know if the duration of the perimenopause is so individual. You wouldn't know if in your case it will be smooth flying and smooth sail and no symptom at all, or in some cases the symptoms may last up to a decade. Can you imagine that, waiting for this important time points 12 months after to start treatment?
And a decade can be 15% of your life, right? That's a significant amount of time. And and this is also the kind of a prime time in a way, right? That could be the peak of your career, peak of your motherhood, or whatever that could be.
Yeah. But you mentioned about the cognitive impact and altogether as the health impact. And I'll go back to what Sarah mentioned in terms of the different, the types. So I mentioned the premature ovarian insufficiency. This can happen from the age of 20 to up to the age of 40. So during these years, if the estradiol levels actually in the premature ovarian insufficiency up to the age of 40, it means it can happen at any point from even there are cases which are described before the age of 20. Women lose their reproductive function, but it's less gradual process than when it happens at the usual age of menopause around the age of 55. And this means very rapid onset of the symptoms in most cases. And this, if one is, let's say, in their 20s, 30s, they're very active with work, the symptoms can be, again, part of the typical menopause symptoms, in many cases much worse. But so I'll start with the usual, the hot flushes, the risk of bone loss going to fractures later on, joint and muscle pain as well, problems with concentration, problems with mood irritability that would impact personal relationships, work, the mood changes and the impact on sleep. This will have an effect on, if one can't sleep, there would be less energy during the day. And all this kind of goes back to the cognitive function, especially there is a research which supports that, especially for women who have premature ovarian insufficiency or early menopause, the effect on the cognitive function is even bigger. And they're the ones who are more likely to suffer with increased risk of cognitive decline early on if they don't start treatment on time. So I mentioned about the premature ovarian insufficiency, and then the early menopause is between the age of 40 and 45. And in both of these groups, before their periods stop, they will have a long time when they will be having symptoms during the perimenopause. And then with the typical onset of menopause is between the age of 50 and 55. But going back to what would be the impact in terms of the healthcare, many of these symptoms I mentioned, joint pain, muscle pain, concentration, fracture in some point, weight gain, depressive symptoms, the night sweats, they wouldn't necessarily be happening at the same time. So women would not necessarily link them together. And they're usually in a situation where they would be going to the GP, oh, I have this joint pain is getting quite bad, they may be prescribed one thing. They will go, I really feel depressed, and be prescribed the antidepressants. And it might be, again, let's say hair loss is very typical. So that may prompt them to look for a different solution for hair loss. Some women would report palpitations, like rapid heartbeats, which would be making them have referred to a cardiologist. And very often, one of the misconceptions, and I will go more into detail with the misconceptions, is having like memory gaps and all these. They may start worrying if I have dementia, again, they may even have a referral for Alzheimer assessment. Again, it may happen, but at the same time, they would be concerned about the risk, and that's why I want to open here the misconceptions. And it's important to keep the different, like, it can happen at any point, unless one. Usually premature ovarian insufficiency comes with, there might be some family history. Like in my case, I knew my mother had it, didn't make me any wiser. I still waited till the very end when it hit me, but her mother as well. So there is the genetic component, but usually people may not know. Early menopause, again, you wouldn't know, but it may, again, have perimenopause up to a decade. And then the usual menopause I mentioned. But the misconceptions are during all these groups, which may be diagnosed with premature early menopause or menopause. The misconceptions are more or less the same. I would say one I already mentioned is that menopause starts all of a sudden, which ignoring the long perimenopause period. The second, what would be a second one? I would go for weight gain. That the one I've heard most often is, yes, I'm putting on weight, but I'm afraid that if I go on HRT, I will put even more. So it's this connection that if one is putting on weight, but if one starts HRT, the weight will go even further up. Actually, it's the opposite. Most women find that indeed there is some weight gain during the perimenopause and menopause, but it's important to look at what's behind this. It's usually they may have less energy to exercise, they may have the depressive symptoms, so they may feel tired, and as a result of this, if they have depressive symptoms, they may just comfort eat. So much of this also, if they don't have the HRT, there would be this metabolic disbalance which is not addressed. So that would lead as well. We know the putting on weight is usually around the stomach, so that would also worsen any metabolic issues. And really, for me, that's a very important myth to address, because what I've seen is women who are on HRT at the dose level which is best for them, they would go back to their usual weight because they will have the energy, they will feel back to normal, they will be more motivated to exercise. So I would really keen to address this myth. Another one is the danger of HRT. And I already mentioned about luckily this is well addressed in the NICE guidelines in terms of breast cancer risk. So people talk about, and you can see it in the social media, there would be this flashy big front page, estrogen causes breast cancer, and that's how it was reported with this infamous study in 2002. While
disastrous study.
Disastrous, yes.
Yeah, wrongly interpreted as well.
Wrongly, it was wrongly interpreted and reported. And then, but even with the disastrous study, what the media picked up was this unfortunate misinterpretation of the breast cancer risk, which wasn't as high as they reported. It wasn't mentioned that this study was done with women in their 60s who started treatment much later, which also increases the risk. There is an optimum window of starting HRT. Many of them had started much later. It didn't mention that they were usually prescribed on the old type of synthetic estrogen, which was made of horse urine, the conjugated equine estrogen. All this was ignored. And also what they didn't mention is that even this study had found that HRT decreases the risk of heart problems, that it decreases the risk of colon cancer.
Yes.
And it was already there, but
yes.
it decreases the risk of osteoporosis. So even the disastrous study had positive things which were completely ignored.
But even the increase in the breast cancer risk, because I think that this is what everybody focused on, is so tiny that it could well be considered as accidental. And if you consider other things that you've mentioned, forget the alcohol, because we know it's carcinogenic especially for breast cancer in women. But even things like the absolute numbers were, again, close to erroneously, like it was completely negligible. It's like going to swimming in a sea, and I'm not going to swim in the ocean because I'm worried about the global warming and the sea levels will rise. Well, yes, they will, but it's like it's almost insignificant. And then when you add weight gain on top of this, that is related, right? And even if it's properly managed, right? Again, symptomatically, that alone is much higher risk than putting the hormonal therapy back on. And I think what we're forgetting to address here as well, that HRT, this is not giving people additional hormones. That's just restoring back what is normal, right? It's not the same as, for example, if you're a fertile woman and you're taking oral contraceptives. That's a very different concept, because they're going on top of what your body is producing or manufacturing. That's just restoring back to normal, right?
And Maciej, you're making a very good point, because the pill has been normalized. It's, so many people on the pill. But in fact, the pill is synthetic estrogen and progesterone. The pill is synthetic. What is available now for menopause management is the body identical. So women, of course, they're the synthetic ones, and that's why one needs to be well informed when discusses with the GP what can be prescribed. The NICE guidelines also mention that it needs to be a discussion with the GP. The GP needs to inform what the options are. But at the same time, it really, the focus should be, there is the option which is body identical. As Maciej said, you need to top up what is going down with age, and once you top it up, you're just coming back to normal and you don't have to suffer. I think that's the whole point. Why suffer when there is something available and one can do something about it? And the options are available on prescription via the GP. It's sometimes there are problems with certain areas where they may have shortages, but still one can get it. And going back to my personal experience, is I had to have a discussion with the GP to negotiate what I thought would be which option I would like to go for, because initially I was prescribed the tablets, and I, after discussion with the menopause specialist, she suggested that it's better to have it transdermal. Again, this may change, but when people consider the benefits between the different ones, so I'll talk a little bit about what are the options. So the options are, thinking about the hormones, we have the estrogen, which can be, again, body identical or synthetic. And the options are tablets. The tablets can be on the body with body identical or synthetic. And we have the transdermal options, which are with bioidentical patches, we have their pellets, which are less frequently used, but they're the patches, the cream. There is a spray as well, which is super convenient. There are pessaries, rings, so different options with bioidentical estradiol. There are different forms in the body. It's not just estradiol, but that's the most popular. Then with the second hormone, progesterone, I mean, it's also the combined pill, the combined HRT pill usually contains the synthetic progesterone. But if one wants to go with bioidentical, there is the capsule micronized progesterone. And as well, it can be used as a pessary as well if one has intolerance. And it's important to know this because it's not just, it's known progesterone as the hormone protecting the pregnancy, which is true. In the NICE guidelines, they make this distinction that if the woman has a uterus, of course, she will need the progesterone or progestogen to protect the uterus, and if not, she will need just estrogen, which many menopause specialists now know that some women may actually benefit, even if they don't have uterus, may benefit from the progesterone, because I remember when I was switched from the pill, which was combined synthetic, to estradiol and progesterone capsule, I didn't expect any difference. I knew that the topical ones are suitable because they don't carry risk for venous thromboembolism. They don't carry the risk for stroke. They don't carry the risk for having negative impact on the metabolic markers. They don't increase LDL levels like the bad cholesterol. So all this, that was what I was considering. I'm not a risk group, so women who are overweight also should be on the topical transdermal. But I knew why it was done, but I didn't know what to expect. And for me, I realized the day after I started the progesterone capsule, I felt so calm. It was like supernatural, and it continued. And I'm saying this because women who may have sleep difficulties, the progesterone is given in the evening, and that can also help with sleep. It makes people calmer. It has more benefits than just protect the uterus. So I mentioned about the progesterone and, of course, the testosterone, which, talking about myths, like I'm ashamed to say, but it was later in life, not at medical university, when I heard that testosterone is equally important for women as well as men. And that's a completely different topic as well. The dangers of just thinking about purely men and female hormone, because we're not talking about men now, but estrogen, for example, is also very important for men, and men can have lots of issues if they have low estrogen. And so men thinking just testosterone, women just estrogen, but of course, women need less testosterone than men. But what I learned later in life was that women produce 3 to 4 times more testosterone than estrogen.
Yes, it's actually the most produced hormone in women, right? Just because it's many times less than it is in men, it is still the most produced hormone in women as well.
Exactly, and it's totally ignored. And there are, of course, the details which don't sure if we'll have time to go through now, but usually women with premature ovarian insufficiency suffer the most because the levels of 4 hormones drop so quickly. For women with the normal onset of menopause, usually the decline is more rapid for estradiol and progesterone, and testosterone is in a way comes later as decline. So that's why it's not thought about at the same time. But it's still important to know that testosterone is important, going back to the cognitive side. It's important for optimal executive functioning.
Yeah, mood regulation, right?
Mood
Memory.
regulation, memory, concentration, ability to focus, of course, bone health, muscle strength, all these energy levels, and it's so important. So it's not just estrogen and progesterone. And luckily, well, in the guidelines, I mentioned it's referred just for hypoactive sexual dysfunction. That's the official indication it can be prescribed for. I hope all these other effects will come into the picture as well. Of course, the studies need it, but it's at least one can find it. The downside of this is it's just the menopause specialists sometimes the only available preparation with the female dose level is androfen, which is produced in Australia. So one has to import in. That's additional complications.
Yeah,
So,
it's not readily accessible, and I think that typically in private care, especially in many countries, women will receive significantly reduced male testosterone, which is again something that needs to be carefully dosed, because the male dose would be many times over of what is necessary for a healthy female. So again, that's a problem, right? So you're trying to manage problem using the tools that are available, but the tools are just not there fit for purpose, right?
Correct. And it's but still at least we have access. I mean, I had next to me like how it looks like this is the testim gel, and probably wouldn't be very easy to see, but because it's the male dose, men need to use a few times during the day, every day. Women have to use it 1 pump every other day, which is not the ideal. There are also the sachets, and they look like this. And because this is again the male dose, when I start using it, I need to make sure that this lasts for the whole week. Again, I'm super grateful that I have access, but obviously there is something which can be done moving forward to put the female dose into it. And what really I find it's strange is that 15 years ago there were patches with female dose testosterone and women had access, and the reason why the female dose testosterone was discontinued was purely commercial reason, nothing to do with safety. I've spoken to gynecology consultants and they were all saying women benefited a lot, everyone was happy. Yes. And
it's almost like we are going back, right? Rather than making progress in something that is well evidenced, works in practice. But and again, this is this gap between what's in the books and what works in real life. I mean, it's just yet another example of that, right?
Yeah. And it's easy to see how this can happen, because even with testosterone, if one opens the patient leaflet, there are side effects described there, such as acne, excessive hair growth, enlargement of the clitoris, and deepening of the voice. And one may get a bit concerned. But the reality is, if one uses the female dose, one would never experience any of this.
Just bring it back to normal, right?
Exactly. And even better than before. So it's really important to address this. I think it's the people who are in the menopause treatment space know that's something which is worth. It's kind of the balance, because of course the pharma companies, they're obliged to put every single adverse drug reaction which has occurred. It's like they're obliged to do this, but at the same time, people perceive with all the negative press and people may read it and think, "Oh, am I at risk of this?" And one example I'm thinking is the vaginal estrogen, the tablets. They still carry in the patient leaflet the same side effects as the synthetic estrogen. Same with the gel and the spray, and it really scares women when in fact there are no studies which confirm that the estrogen which is administered as a small tablet in the vagina has any negative side effect. But they have to say it because the studies are not done yet. But of course, there are also small wins. I believe 1 year ago, finally, the vaginal estrogen is available without prescription. I think that was considered actually a massive win, because now women can go into the pharmacy if they're. I mean, I would suggest always to speak to your doctor, but it would be possible the pharmacist to give them the vaginal estrogen, which something which reminds me is it's actually quite common. I didn't realize that even women who are prescribed HRT, 25% of them may still experience vaginal dryness, pain during intercourse, and all these symptoms can be very easily well managed by the vaginal tablet. And there is not much talk about this, because again, it's not a topic women may feel comfortable discussing with the GP. In some cases, it's considered to be, just tough it up, bear it, like it's part of life.
Yeah,
But
again,
actually,
it's minimum standard again,
minimum
rather
care.
than thriving, right? Or but estrogen is also neuroprotective,
Yes,
right? It's at least considered to be. It's one of those medicines
it
that is
is.
considered to be neuroprotective. So, because I think it's important in context of for women for aging, right, and related to the brain function decline as we age. Right, we know it's inevitable, but there are things that we can do to slow the age of the decline, right? So clearly, we already see that there are benefits of HRT way beyond just preventing the symptoms of menopause, right? It is very likely that it allows you to keep your mental faculties, let's say, in their fullest splendor for longer in life, in a way. I think it also becomes clear that the impact of the hormonal changes as you go through life will have an impact on the rate of your cognitive decline, like for example pregnancy, right? Or that's something to take into account. So let's talk about this neuroprotective element. And one of the most common thing that women notice themselves, because they speak to us, they say, well, I get this brain fog, right? Where is this coming from, right? And there's, again, it appears, or if you go and ask a GP about this, nothing I can do about this, right? Maybe you work too hard, or maybe you should sleep more, whatever the typical advice would be. But it's a very common symptom, right? You're young, you're at the peak of your professional career, and you suddenly start, what is brain fog?
Right. Well, it's the way I've heard this described as well is women feel it's like their brain has become like this cotton wool. They can't gather their thoughts. And the brain fog, they may also include they can't find the right words. Concentration is impaired, but it's more like you feel spaced out. Part of this may be periods of just you're talking about something and all of a sudden it's like blank.
Yes,
You don't know where.
because so the verbal memory is impacted, because we know this from like large cohort studies, right? The Swan study, they showed this clearly. And attention dips, right? I cannot focus. And we know that a lot of people, I have adult onset ADHD or whatever that is, inability to focus, they being prescribed amphetamines, right? Or the derivatives, Ritalin and mental health medicines to improve a symptom, but it's not going to work, right? That's not what the problem is, right?
Yes. I mean, aside from the fact that ADHD people who already have ADHD, it will worsen during the menopause if they're not treated
Yes,
with
the
the
attention will
hormones.
drop even more. Yeah.
It
Yeah.
gets worse, but as you say, some may not have it, but their symptoms mimic that. And in terms of, I think the biggest issue is women themselves may feel, oh, I'm imagining this, but there is, what we know now is there is the physiological reason for this. There are receptors for estrogen. There are different estrogen type receptors in the prefrontal cortex, in the hippocampus, all these brain structures which we
So it's
know
again,
are
it's thinking and memory, right? It's
thinking and memory.
remembering and being able to think clearly, right? Make decisions,
Yes.
the higher level executive functions, right?
Yes.
Yeah.
So if we have so many estrogen receptors, different types of estrogen receptors in this brain area, I mean, we have in the whole brain, but specifically in this brain area, clearly it has a function. And if somebody starts having symptoms, I mean, there are already studies which show that that's the case. But for me, one of the symptoms, one of the things which has been confirmed is actually the speed of information processing is reduced. And for a professional, how horrible is that? Not to be able to concentrate, to know that your brain works at a slower speed. And as a result of this, I mean, it's a known fact that many women at the peak of their career, once they start developing the menopause symptoms, and if they don't get the appropriate help, they may consider completely leaving work, and that's known.
And if you add burnout, burnout on top of this, which likes to creep in at this time, because you suddenly become again less resilient, right? And
exactly.
And what if you get you go to your GP, and what's the thing that happens often? You get put on antidepressants, right? It still happens, right? To help you with those symptoms, and it's going to make everything worse, not just today, but 10, 20, 30 years down the line as well, right?
Yeah, well, I mean, to be honest, at least it would be good if they at least go to the GP, so they may be lucky. And
many don't.
Going back to the guidelines, I think now with the updated one, the GP should know that HRT is first line. Of course, they may still need antidepressant at some point, but in the guidelines, another thing which was updated was that they could be referred for CBT therapy. So that in addition to HRT, the guidelines are clear. It's not just CBT, but those who, for whatever reason, don't want to take HRT. I mean, I can't imagine that, but there are women who wouldn't. They could be referred for CBT as well.
Yeah, which we know it's probably not going to help, because again, that's not where the problem is, right? There's some symptomatic relief and self-reported outcomes that last, 15 minutes after the session or so at best, because it's not going to address the problem, right? It might give you some strategies that you are not aware of, but it's not going to make the problem go away.
But at least, I mean, going back to what one has access to, at least they will have it as an option. And in terms of going back to the effect on working professional women, some of them may drop out of work. Others may just refuse to go for leadership roles once they're at the stage of their life when they have worked all their life to get to this next step. So the impact is, let's say, if one has symptoms, doesn't go for treatment, the impact is not just the hot flushes and the night sweats, not just the impaired sleep, but it's in terms of cognitive, the self-confidence will be decimated. And maybe that would be, in terms of CBT, that may help with, but of course the main thing is you need the hormones to be there. You can't think yourself out of low estrogen levels.
Not going to happen.
No.
Yeah, and I think, Dani, it's important because I think in January this year, so relatively fresh, there was a massive study I published on a hormone replacement therapy, menopausal age, and the lifestyle factors. And it was a pooled analysis, I think, of more than 6, is that correct, Sarah? We read it at the beginning of the year. I think more than 6 million women, which confirmed that early menopause, again, primarily linked to the hormonal decline early on, raises the risk of dementia of, I think, 40 by up to 40%, and that's after adjusting for vascular factors, right? So that just that dip in your cognitive decline, which is completely reversible and correctable, will suddenly put you on this rapid decline, dramatically increasing the risk of dementia early on. And it's not going to be treated with CBT. It's not going to be addressed with, thinking yourself out of it. It's not going to be fixed by Ritalin. It's not going to be fixed with antidepressants. All you need to do is just get back your hormones to your normal level, right? And all the other symptoms will improve as well. That's all it takes, right?
Yes.
Yeah.
Yeah. And it's with dementia and menopause, it's a bit complicated because I get sometimes frustrated because you will see even in the media, and there one research says HRT may increase the risk of dementia. The other one, which is not controversial, is what you said. Women with early menopause, premature ovarian insufficiency are at greater risk for dementia because they will have they will have much longer period without estrogen. But
these are adjusted numbers, right? So we're not talking about the ApoE4 gene carriers. We're not talking about the vascular risk factors, related to your activity and cardiovascular health. That's purely on the cognitive. It's purely cognitive related risk.
And that's also when you mentioned the ApoE. It's some studies, if they report that HRT may, in their, usually the small study, if it reports HRT may lead to small increase in the cases with dementia. Again, are they taking into consideration the ApoE profile? Because we know that that's a risk factor, and that's why there is these differences between women who may have this genetic predisposition, of course, other risk factors. And we're going back to lifestyle as well. We know what would be a protective modifiable factor to prevent dementia in terms of, again, going back to sleep, exercise, social stimulation, and all this is important as well.
But something you said at the very beginning, Dani, was you already had a lot of the lifestyle habits in place, and in a very routine way, so that if there were any changes to them internally, you would be able to easily pick this up and be able to separate whether it was just a bad day or truly part of the perimenopause and menopause process. So this kind of level of self-awareness physically is rare, I would say. And especially when it comes to the subtle changes that happen, not just a full brain fog, but subtle changes that will happen. So what do you tell women when maybe they are starting to notice something change? Well, first, what do you tell women who maybe don't have that level of awareness yet? We're not talking about making all these changes now for the sake of perimenopause and menopause. We're talking about making changes so that when you're taking care of your brain long enough to know when you need to get something in place later. And then, what is the difference between, I think I'm entering this phase and it's just a bad day? How do you help someone do that without completely medicalizing what they might be experiencing? Because we're also talking about, there's a difference between feeling depressed, feeling anxious, having depressive symptoms, and having underlying cognitive health that is contributing to that. And it's very easy in that mental state or that change to say, no, I'm depressed now. That's very different. So I know that's kind of loaded, but let's start with women who maybe don't have these kinds of awareness of their own bodies and minds, what do you do, and then how do you tease this apart?
Yeah, great question. It is difficult, but it's, yes, some symptoms may be subtle, but as we know, people usually don't go to see their GP for subtle symptoms. And one of the misconceptions is that the most bothersome symptom are the night sweats and the hot flushes, which obviously would be extremely uncomfortable. When I was doing the clinical trials with menopause, I was really feeling so bad for the women, because the studies had as the inclusion criterion they had to have the average of 49 hot flushes per week, which meant 7 hot flushes per day. And the way this is described, as a hot flush is usually not just intense heat in the face, neck, and chest, but it's like the head feels like it will explode. And imagine this 7 times a day. So it's it's not that subtle. That's my point. Once it starts, it may not be 7 per day. It may be one a few times a week, but it's certainly noticeable. Many women will report waking up during the night, having to change a few times during the night. Again, that's it disrupts that. It's obvious.
Yeah.
But it's surprisingly, it's not usually even though most people associate menopause with hot flushes, that's not why people usually makes them to go and see their GP. It's usually problems with concentration and the brain fog, because we are working women, and it happens during the time when one may be at a more senior level, or regardless of the situation, it has a massive impact on the quality of life. And I think that's actually the symptom which is more likely to trigger women. Especially, it may not be, well, unfortunately, people wouldn't, after a few days, a few weeks of poor concentration, but it's usually you don't feel like yourself. And that's what I also remember personally as well. I know I would be reading, working for hours, and all of a sudden it may not be the same. So I would say people, even if they're not aware, would still
Notice it.
Notice. And so that turns out to be the first reason what urges women to look for help. But of course, the challenge of that is that they may be, especially if they're younger, and especially because not everyone has night sweats and hot flushes, they may have one symptom more than the other. If it's predominantly concentration issues and they may not link the other symptoms, they may be prescribed antidepressant in this case. So it is. On the other hand, actually, these days there are more resources where one may see that, well, I may have this symptom. Could it be menopause? And there would be this list of 30 different symptoms. So if one starts to look into it, it's more likely that the puzzle may fall into place. But for those who don't have very severe symptoms, because we're talking about, suffering severe symptoms. Severe symptoms are in around 30% of the women. A small percentage of women don't have any symptoms they're aware of, but most women may have mild to moderate symptoms. And it's really being aware early on. Many small symptoms may be part of the big picture. And if one becomes aware, well, I didn't have symptoms which one that would never consider a part of that. I didn't have such a bad IBS, irritable bowel symptoms like bloatedness, and it wasn't that bad before. But now it's starting to be an issue, and I have, or let's say, joint pains more often. And my friends, like my husband, is saying I'm more irritable. It's getting worse. It's all this can make the puzzle, and it doesn't have to be really, really bad.
Right, right. And even a small change, especially at work, let's use the
Yes,
professional example.
yes,
And even a
Absolutely.
lack of focus for 5 minutes could have an impact on your ability to make a decision, especially if you're
yeah,
in a position where your role is essentially only decisions that are going to move you and your team and the business forward. So I guess it's also empowering people not to ignore those.
Mm-hmm.
But also, are there changes that an individual could make, or um, even workplaces maybe as well, to make the to address the almost inevitable cognitive function changes, even if you are being treated and on
yeah,
treatment for this and
yeah.
paying attention to it? What are some small changes someone can do to maintain their brain health while they're also navigating that? Is there something that you would recommend?
I would say definitely one needs to go to the basics being
Yeah.
right.
Okay. Yeah.
So with cognitive health, I would say the basics are sleep. Try to get optimum amount of sleep. Yeah, it may be challenging, but if one starts treatment, that may actually be solved, and still, it would still be sleep would be super important. Exercise. We know the target is at least 150 minutes of moderate exercise per week, which is not difficult to get to by half an hour walk every day. So exercise is super important for mental health. So any type of exercise would be great. And nutrition. I'm very interested in supplements, so that's a completely different topic. But with the nutrition, we know that the Mediterranean type of diet seems to have the most benefits in terms of fruit, vegetable, food high in omega-3 as well, lean meats. That would be important. Avoiding takeaways and any high sugar containing drinks or snacks. That would be important as well. So I would say the basics are sleep, exercise, nutrition, and in terms of brain health, social connection and learning things. So if we can do this, we have the basics right, and we can top up with HRT and
Yeah. So that
yeah,
the feelings, the emotions that come around these observable, subtle changes don't derail you from hopefully the simple things that we're already doing, because
yeah,
we're also trying to address the decline. There's still decline that's happening with age. Symptoms and emotions of menopause just make that a little bit more complicated to stay focused, I think, is what we're
yes.
on your basic health. I think that's kind of, and lead a family and a career and all the other things that you've probably been able to manage well, and then this happens.
Yes,
It's difficult to
but that's what I mean. Even if we have everything sorted with the basics, in what we just mentioned, as much as that as well, we can't think ourselves out of low levels which are important for functioning of every cell of the body. And I used to, when I was doing other training before, I like the analogy of knowing how important estrogen is. I like the analogy, it's the fuel for the body. So if our tank is low, as the estrogen level keeps dropping. If women in menopause have almost zero. If we get there, how can we think ourselves out of it? Even if we eat right and sleep and do everything else, the hormone is not there. So we do need to think about that. And of course, in addition to what I mentioned, we know that there is the CBT therapy, meditation, mindfulness, but it's very often we hear, I just want all natural, and but we already know that the body identical hormones are natural. They just replace what the body produces naturally.
Yeah,
And
what's missing? Yeah.
exactly. And in the past, for those who just think, natural, and in the past, women didn't live that long. So, menopause was the end of life type of stage. And now, if we're in our 50s with the expected lifespan to go up to 100, hopefully, it's how do we want to spend the rest of our life? With empty tank and everything suffering, it will be miserable.
Yeah.
But also this natural myth, I think that's something that we should pinpoint. Tigers are natural, so is Ebola, right? And
Yes.
not everything that's natural is necessarily good for you, right? It's something to
Exactly.
remember. And I
Yeah.
think just what I believe there's been a large polysomnography, which is sleep studies, that show that the hot flashes or any type of vasomotoric, let's say, disturbances, have a profound impact on slow wave sleep. So they either wake you up or they will flatten or take you out of the deeper phases of sleep, which on its own, right, even when you correct for the hormone levels, hot flashes will, because you didn't have a restful sleep, will increase your sleep debt, and you will have a decline in your executive function next day anyway. Now imagine this happening, as you said, for a decade, right? Because yes, sleep is one of the most important things that you can do to keep yourself healthy, right? But even having the symptoms that women typically recognize as being part of the menopause, right, which is the 2 or 1 or 2 that have hot flashes, so I might need to do something. Well, that on its own will impact your sleep, right? So even if now imagine you're trying to sleep, but there's nothing you can do about this, right? Now that's going to make you anxious, right? Which again, your GP already awaits with the prescription for an anxiolytic as well. Like it's like again, you can easily fall into that circle of what is wrong with me. Why can't I sleep? Like, well, because your hormone levels are not what they used to be, right? And there's a simple solution to that.
Yeah,
I
and
think there was,
it's
yeah.
I just wanted to add, in addition to what you were saying, is think about the risk benefits. If one goes with, because I don't object to antidepressants, there is certainly very good use case,
Absolutely.
and they're super important. But if the main reason for the symptoms is as a result of the low estradiol, and one goes on antidepressants, we know it's very difficult to stop them. It's just an issue which is it's well known. Then also other people who don't get the right support may think, as you say, I can't sleep, anxiety. I didn't realize that was such a big issue, but now it's more in the media, and more menopause specialists talk about this, that some women actually develop dependence on alcohol to help them sleep. So it's antidepressants being hard to withdraw from. Alcohol, which can
alcohol will
create a
not make you,
problem.
but it will not make you sleep like physiologically anyway. It actually makes it worse. So
Exactly.
that's this illusion you get, because alcohol will shorten the amount of time you need to fall asleep, because it's a central nervous system depressant. But it's not. You're not going to go into you're not going to have restorative sleep anyway.
Exactly.
Yeah, symptoms management.
Exactly. And anxiolytics being addictive. So it's and we have, during all this time, we have something which actually helps. So yeah.
Is there a point where it's too late to have treatment? If a woman is just, well, I haven't been sleeping for a year, it must be menopause. I know what it is, but it is what it is. It's too late. Or I've asked my doctor about this. They don't know what to do. Or I don't know. I don't even know what to bring up at this point. What do you tell those women? Because I've known a lot of those stories, unfortunately. And I mean, how many nights of sleep are you going to go? Are you going to allow yourself to go before you think, you know what, I can't do this anymore?
Yeah, that's a great question, and there are actually a few small questions there, which I will mention first. There is a window of opportunity for starting treatment, and it's it should be started within 10 years of menopause. We're talking about the regular menopause, women with premature ovarian insufficiency, the sooner the better. Luckily now we see many women who are able through the GP to start treatment during the perimenopause, which if they have symptoms and they're suffering, that would help massively. But it's in many cases, and that's what I saw as well when I was doing the menopause studies, was women had started treatment. Of course, it may have been synthetic estrogen and progestogen. They may had some of the associated side effects, which, to be fair, some of the side effects like breast tenderness, or some may experience other issues which can actually go down and disappear with prolonged use. But for some reason, unscheduled bleeding as well happens very frequently over the first 6 months.
Okay.
These ones, if the person doesn't have adequate support and they don't feel comfortable talking to the GP, if the dose wasn't right, etc., they may just stop. And that was before, very often was one of the options. The GP may decide, well, you're not dealing well with it, why don't you stop? And when I saw them, some of them were within 5 years after they had stopped. So it's important to keep in mind that within 5 to 10 years, one can still resume HRT if it was stopped for whatever reason. They were on product which they didn't tolerate. Their GP wanted to stop them. They saw a scary headline in the newspaper. But after 10 years, it becomes tricky. It's less likely that the GP would be willing to prescribe after 10 years, not on HRT. So it's important to, if one really stopped or was hesitant to start for a certain amount of time, there is this window of opportunity.
Yes, but it also prevents the potential damage that may happen, right? So
yes,
yeah. So the sooner, typically the better. But it doesn't mean that if you haven't started, it's been 1 to 5 years, right? It's still beneficial if you do this, right? So I think it's a good thing to just speak to someone, to your doctor, right?
Yeah.
As soon as you can. Then you said something powerful. You said something that women often notice as early symptoms. Oh, suddenly, I know my partner becomes annoying, right? Like if something changed. And we recognize this because it's one of the brain's most fundamental functions, right? Your brain tries to preserve your own identity. So we're not going to go into the details, but I think something that our listeners will easily relate to. It's much easier to spot certain problems when in someone else than it is to see them in yourself. It's typically the environment that, like, if you have dementia, it's not a problem for you. It's the problem for everyone around you because they can see the impact. Your brain protects you, prevents you from seeing the impact it has. So let's try to explore this. You've mentioned you talk about your mom who went through early menopause. What did you notice? What did you observe in your mother when that started?
To me, because she's a very positive and happy person, so that stayed. But she was always complaining about memory issues. Oh, I'm having dementia, or I can't remember this. And she's somebody with extraordinary good memory. And for me, that was very strange. I was concerned because she was in her early 40s. And over time, and it's a pity because she was one of the victims of the Women Health Initiative study. It was exactly during that time. Everywhere in the press, there were just these horror stories, warnings, and she and because all this continued for almost 20 years, she just missed the time. And for me, it just breaks my heart knowing that it's what I'm that's the area where I'm willing to do more, and still there is so little I can do about my own mother. She's out of the window of opportunity, but for her, the cognitive symptoms were the most stressful and had the biggest impact on her life. And probably it's not surprising that for me, the cognitive symptoms were also what I found the most disturbing as well. And in my case, the full resolution of full cognitive, in terms of difficulty with concentration, actually was once testosterone was added. So and that's why it's important, if one has the symptoms, it may not be the initial dose, the initial treatment. One needs to discuss everything which is available to deal with the symptoms. So it's it can vary. It's not one symptom across all women who have menopause symptoms. That's the challenge. It can be different, and the cognitive symptoms I find can be one of the most disabling, with the biggest impact on quality of life.
Yes, and rarely recognized by the women or by doctors as related to menopause, right? It's
correct, because usually people think hot flushes, night sweats, menopause, but yeah.
And by the way, it's a similar situation in men, but not related to with aging, typically related to testosterone decline, right? It's not just muscle mass and mood regulation or anxiety. It's very often similar story. And men are typically even less aware of that, noticing their own symptoms or cognitive decline.
True. And I always thought men are kind of in a better situation in this respect, until I had a meeting with my GP as part of the usual follow-up for the HRT, and he mentioned something which made me realize, okay, I was wrong about men being in a better position, because you see Viagra is often not with prescription. There is the male dose testosterone, but what he said was that now we know that men can suffer with low estradiol, and that can be confirmed with the blood test, and the symptoms are known, but there is no guidelines which would support the prescription of estradiol, which would sort the problems. And
zero.
I think it's not good.
Yeah. Can we go back to the social connection is important, not just for preserving your cognitive health, especially as we get older, but what you're saying about being able to recognize changes in others easier than you will recognize or accept the changes in yourself. That's also why having a support system or trusted partners, could be your spouse, it could be anyone in your family, friends, could be a mentor. This is really important. We've talked about this from a career perspective and just from a quality of life perspective, but that's exactly what it's for, is this reflection. And if you're someone close to you who you trust says, your mood is changing, you're complaining more, your memory seems to be right. I mean, if you think back to maybe your own examples, it's not meant to make you feel worse than maybe you feel, but it's to enable you to get help or treatment earlier, so that you can return to some quality of life that will help you continue to engage with your support system in a meaningful way. So I'd also encourage our audience to think about, again, we've talked about this from career. If you don't have mentors or management, or if the business you're in isn't really is conflicting with what you need, like address it. You can change it. But the same is true for your own health and especially your own cognitive health, that maybe is it's more difficult. You can see your body physically change on the scale, but you can't see, the brain changes in the same way, but others can. So, and then when we are getting the social connection that you can maintain later on becomes important, because then it helps deal with loneliness and isolation and all the things that older people, as their physical ability declines, those risk for that increases. So that's all straightforward. But maybe the pausing to reflect on your own support system and the kind of support that you offer others when you see those changes is just something to help maybe reflect on. I just wanted to say my piece on the support system. And
yes, of course, it is super important. Yes, you're absolutely right. It can be challenging. This is why I think just talking about this, and hopefully more men hear about this, because as you say, as being in a partnership, one would be able to count on the other person noticing. So increased awareness would certainly help. I don't know, with friends, if they would be comfortable saying, "Oh, you're more irritable," or I would expect from more closer people. But it's it's important to get the awareness, so that more people know that it's not just hot flushes. It's especially the cognitive symptoms. It's so important, and it's not. I mean, I hope it happens less, but women have their cases where women have considered taking their life because they felt trapped, and that was it. And I'm just horrified when I hear such stories, because literally all the symptoms go back to normal and people feel back to normal within a few weeks. It's not a long treatment one has to endure. It just so simple. And yeah,
it's also important. It's also people who never would have experienced that sort of level of that depressive state. That's also a sign that there's chemically something changed that could be addressed.
yes, and also it is available. I mean, we are opening I've seen research which points that people who have previous periods when they had depression, they may be more prone to have more severe symptoms. But equally, so that also creates its own challenge. If somebody had a previous history, they may say, "Oh yeah, it's another one," rather than think about, "Oh, is menopause because of that," making it worse. I think it's more likely to be noticed as something unusual if one hasn't had previous history. So that's the challenge if one had previous. But it's just, on one hand, it's okay. In my ideal world, we know we are not there yet. But if we had this ideal world, I would say what would be put into place would be starting from medical university. That would be part of the curriculum, starting with school curriculums. Teenagers will have some idea that menopause is not just hot flashes, can start different stages. There is long perimenopause period. So it would be the whole class studying this, so boys and girls would be aware. Then women will start once a year. There would be a 10-minute talk with the GP, starting to create awareness of all these multiple symptoms. and checking if something may have changed. Then there would be another one in their 30s and another one definitely in their 40s, and to track if symptoms may have started developing. You mentioned this in terms of spotting early onset of symptoms. That would help massively.
Yeah.
But the situation now is women have to wait until it's really bad. Even the guidelines are actually suggesting that the treatment is for moderate to severe symptoms. I would say, why not think about the mild symptoms? But also, the guidelines refer to treatment is with the minimally effective dose, which again makes people think they should be at the lowest dose. But in fact, what is minimally effective dose for one person may be the highest dose for the other.
Right.
And it's
minimally effective is not the same as minimal dose, right?
Yes,
and that's
exactly.
something that sometimes, unfortunately, doctors struggle to understand.
Yeah. And it does create lots of a situation where one would be kept on the minimum dose, still have symptoms, but the GP may not be comfortable to increase to what would be the minimally effective for this person.
And it also shows how, I think also shows how far the thinking is from thriving, right? For treatment, as if it was a disease, right? For treatment of severe symptoms. You've mentioned mild, right? Why not mild? Well, why not prevent it? Right? It's something that, why wouldn't you do this? I mean, there are lifelong benefits, right? If you do this,
yeah, exactly. I love the idea of prevention, and talking about prevention, it's already known, even in 2002 with this study, that it will reduce the risk of bone fractures. We know the impact of a bone fracture later in life. It will decrease the risk of cardiovascular events. We know the impact of those in terms of mental health and thriving with, if one doesn't have to cope with depression, low self-confidence, and all this which might be as a result of untreated symptoms. It's
you just don't prevent symptoms, right? As you said, you prevent colon cancer, you prevent falls, you prevent osteoporosis and damage related to this, right? You prevent the host of, you prevent dementia, right?
Yes.
Yeah, some say you prevent divorce.
I was going to say,
I mean, there's a link between
collapse of your career and relationships,
careers,
too.
and
What are women? What are women most afraid of? Where is the fear coming from when, if someone says, menopause, I'm scared of that time? What is it, and how do we disarm?
In terms of fears, I would look at them as fears of HRT, because of all this, all the things they may have heard in the past, and sometimes, I mean, even now, there are from time to time all these headlines in the media about the dangers, and I would say that's on one side. On the other side is the menopause is linked with old age. Once I enter menopause, that means that's it for me. And for me, one of the reasons why I'm passionate about talking about this is, even though I was, in my case, it started so early, because I started HRT at the same time and have managed to get access to the best treatment available, I feel as good as I was in my 20s. So for me, it felt like time has gone back in terms of energy, strength, mental capacity, and weight has remained the same. And I feel I can do it. It means other people can have the same benefit, and it's just knowing what one can lose if one doesn't consider what's available Yes, I believe we need to talk about yes, this is so that women know it's there. It's possible. It doesn't mean that, even though I agree, I'm not saying I know I wouldn't prevent changes over time, but the fact that I mean, personally, I do remember when you say about fears. Again, I'm aware that I speak. My personal experience refers to women with POI, but I was in my mid-30s, after my mid-30s, and yes, I know I was working 2 jobs. I was doing training in addition to this, so there was this as well. But I remember I was looking in the mirror, and all of a sudden I saw wrinkles, like almost appearing overnight. I was scared. I was scared, and then I noticed changes in my strength in the gym. Then I was given the diagnosis. Then, in my case, divorce happened. So one of the statistics as well, and all of this, all of the challenges in terms of how I felt and what I thought is, oh, that's it. It's that's it. Actually reversed within a couple of weeks.
Wow.
It's you know, it's not something you can expect, because I didn't expect the skin changes to be so reversible so quickly. It's sometimes one would be surprised to see how easy it is to actually manage everything to go back under control. That's what I try to talk about. Just it's so easy to manage if one has the appropriate support and access to treatments, or just the knowledge what helps.
Yeah. So women don't want to enter. Women don't want to enter it at all, even though there are simple things and now available. Can it be prevented?
I would say we can do a lot on the way to reduce any decline. We may not, I mean, of course, ideally, I would always work towards preventing it completely if possible, but I'm willing to accept that maybe not 100%. But if we can slow down, if we can reduce to a big percentage, why not? It's there. We don't have to invent it.
We can.
Yeah, exactly. We can. So why deprive oneself of the opportunity to have a high quality life, reduce the risk of osteoporosis later in life, reduce the risk of cardiovascular disease, be strong, have the cognitive capacity preserved for as long as possible? Why not? We know how we can do it. So, you know, we talk about also the being financially accessible, and these are not new. It's not something which is really expensive. The hormonal treatments are not expensive, so we are not going to bankrupt the healthcare system if we're not in the UK. It's usually everywhere. They're not expensive treatments. Also, having spoken to the women who were on the menopause studies, what I have, for me, the takeaway message is get as much information as you can. The information is available. It's not like before. Now there is plenty of information. Go to reputable sources. I would always refer people to go to the British Menopause Society, even if they're not in the UK. I think it's an immense source of evidence-based information, and it's presented. They have this, if one goes on the website, it's not just for clinicians. They have useful resources, and it's all presented as tables, just bullet points. I would say it's as easy as just print out the tips before you go to the GP for the discussion, it would be perfect opportunity to have this conversation. So just get the information. And another takeaway for me would be, again, based on what I've heard from so many women, is don't give up, fight for your quality of life. It's just because so many mentioned, well, my GP doesn't believe or believes that HRT is risky and refuses to prescribe, or my first GP prescribed, but later I was taken off because I could be, they thought I should be on HRT for a certain period of time, which is not true. And then they stopped. So just referring to one may need to change GP and see another doctor if needed for a second or third opinion, just because, again, things have changed so much over the last 20 years in terms of understanding and options. So don't give up. If it doesn't work once, try again with a GP, find menopause specialist, find somebody who would be listening to you and is aware of the best practice. And I believe these are the two important things. Just also to be aware that things will change. So if something worked at one point, may consider going back to discuss, is there another option? What I mean is, for some women, starting with estradiol and progesterone may be the best at the beginning, and only much later on they may not need to add testosterone. But it's so individual. It doesn't mean one fixes the treatment at the beginning and that's it sorted. It's one of those things where we need to be be aware that it's something which changes. Our hormones change all the time. Be aware that we talk about menopause, but many symptoms can overlap with other conditions. So very often one needs to be thinking about the thyroid. Is the thyroid functioning properly?
Mm-hmm.
Yes, and it's is there another condition which is the treatment, once I'm started on HRT, and if I have thyroid issues, if I'm on a tablet, I may need higher dose of the thyroid hormones. Am I deficient in iron? Like, do I have anemia? Or there's many things which one needs to think about, which can change as well over time. So yes, it's may not just be menopause, but it's good to be aware of all the symptoms, what else might be there. Yeah.
But what you said, the education early that's trusted and objective is, and self-advocacy is too, and that's applicable for anything, really.
Absolutely.
The question from our previous guest is similar. What advice do you give people when they are thinking about changing direction, and what advice do you give to someone who's thinking about changing a direction or making a change?
Any direction, professional direction?
Any direction.
We'll leave it to you, Dani.
I'm asking about professional direction because it's something I'm interested in, but as I said, because I like to look in the future all the time, and I do believe that things will change big time with artificial superintelligence, general intelligence, and one needs to be able to anticipate change in direction. It may be, I understand in this case, we are talking about internally triggered change in direction, but I try to remind myself it could be one needs to be prepared for both internal, external. And if it's professional, I would say know that it is challenging. But if one feels like one needs to do it, there is a reason for this. In the way society works now, it's very difficult. It's not built in a way where we can necessarily enter a job where we are playing up to our strengths. And I believe people consider usually change in direction because they know their strengths are aligned better in a different area. And if that's the case, I believe one should follow this feeling. Well, do it in a reasonable way. There are different ways to change direction, but if that's what one feels is the way to go, I believe it's best if one tries to find a way to do it.
Yeah, I love this idea, and I hope people know what their strengths are, right? Because I think that some of us are not aware of it or not willing to admit it sometimes too. Mm.
Yeah, and again, society is not structured in a way where our strengths are necessarily at school. It's usually just following the curriculum, not necessarily developing individual strengths. So it starts from school and it doesn't get any difference at work. But hopefully that will change.
What advice are you giving Dani 20 years from now?
Oh, from now. Well, we may open a completely new topic because I have my own ideas about what might or might not happen in 20 years. But for me, it's always been a trust myself more, because very often it's in a way it's probably linked to what we've been discussing now. I went in my 30s through a period when I didn't feel myself. I felt I'm a different person. I didn't realize that it was as a result of the hormone changes. My confidence had crashed. I literally felt in my 20s I was very ambitious, and all of a sudden I felt different, not me. And I knew something was not okay, but I should have trusted myself. So it's always, my advice would probably be consistently trust yourself. You know if something is not how it should be, just don't give up.
Yeah.
Yes, well, I can be optimistic with this, but I do anticipate very big changes over the next 10 years for society.
Very optimistic. Great.
I don't know if I'm optimistic, but I do anticipate changes. I try to be optimistic, yes.
Yeah, it's great. And I think there are some fundamentals, though, that we know will not change, right? Whatever the societal fads are or whatever is trendy at any given moment, there are some things that we know for thousands of years will remain true for us, for who we are, how our bodies work, how our brains work. These things are unchangeable. And there are skills and knowledge that you can get today and work towards the things that you know will serve you for the rest of your life, right? Because they served people for generations and for millennia. And because that's who we are, right? As people. And we'll be able, if you invest in the right skills, you will be able to find yourself and thrive in any environment, whatever is at the moment trendy or popular.
Yeah, absolutely. And it's going back to the cognition topic and optimizing cognition. It will be even more important now when the changes which are likely to happen over the next 10 years. In order to cope better with the rapid change, one needs to be able to optimize cognition to the best of one's abilities. and learning different skills will be actually a must rather than I don't want to do it. It would be really almost compulsory if one wants to thrive.
Yeah. And now we have tools that are really good at taking away those cognitive powers away from us, right?
Mhm.
Attention, cognition, thinking.
Yeah.
Yeah.
Yeah. Well, it's a big topic, yes.
We'll have to continue our conversation then.
I think we have so many things we can go into detail, so yes, absolutely.
Dani, we will link a few papers, and we can link the British Menopause Society as well. For people who might want to just ask you questions, where can people find you?
I can give my my LinkedIn probably would be developing now a website where it would be easier once I get on the website.
Okay,
LinkedIn would be in the first instance.
Okay.
So we will add your website address. The moment you have it, we'll add it to the podcast notes as well. So it will be there.
Thank you so much.
Yeah.
Thank you.
It's such a pleasure to talk to you today.
Sheer pleasure. Let's stay in touch and decide what else we want to cover in detail. But it's my pleasure, absolutely.
Thank you.
Thank you very much, Dani. And
Thank you for having me.
I'm sure that this conversation will help a lot of women to find their balance and get back on track in life. So thank you for sharing your knowledge and experience.
My pleasure.
With us and with our listeners. It's been a pleasure. Thank you.
Thank you. Take care.